So, very good evening, one and all. Very good evening, seniors, juniors. Very good evening, fellow doctors. A wonderful pleasure always to connect with each and every one of you. And thanks for actually joining on a weekend Saturday. We do understand that many of you would be having a very busy OPD today. As we all know, the typical Asian Indian phenotype that we have seen in our clinical practice is characterized by an increased insulin resistance. There tends to also be a reduced beta cell function in our patients, a greater tendency towards abdominal obesity, and a clustering of traditional CV risk factors like hypertension and dyslipidemia. Also, we all know of late of this new entity, glycemic variability, which we are very sure some of you do use in your clinical practice. To throw some light on the same, as well as how does this impact, and how does pharmacotherapy impact patients with type 2 diabetes in the Indian scenario, we have learned experts from the field today. I have the honor of introducing our esteemed moderator for the day, Professor Dr. Anirban Sinha. Dr. Sinha is Associate Professor Endocrinology at Medical College Kolkata, a visiting endocrinologist at Amri Hospitals. He's the chairman of the Ethics Committee at Central Hospital, SER, as well as the program chair of MMSc Endocrinology at Texela American University. He's in the editorial board of 3 journals and has received numerous awards during his illustrious career, including the A.V. Gandhi Gold Medal, the Young Thyroidology Rising Star, as well as the coveted fellowship of the American College of Endocrinology. On the same note, I have the distinguished pleasure of having Dr. Sinha with us. Dr. Sinha, over to you.
Thank you. Thank you for this nice introduction. And in this weekend evening, we are going to have a great discussion with our legendary speaker, Professor Antonio Cerillo. So I'm sorry if I pronounced it wrong. So we have a very important point to discuss today, that is the glycemic variability in the diabetic perspective and why it is so important, what can be prevented. We have learned from the previous experience that glycemic variability, be it inter-day or intraday variability, there are lots of complications can be increased, though your HbA1c remains the same. If there is a significant fluctuation of blood glucose, then you can end up in more trouble, more complications than the same HbA1c with the smoother glycemic control throughout the day. So with this small introduction, because I don't want to spoil the time, we have our very esteemed speaker, Professor Antonio, who is head of the Department of Diabetes and IRCT's multi-specialty hospital in the Milan, Italy. He is the president of European Association of Study of Diabetes in the group of diabetes and cardiovascular disease. He's also been a member of board of development of new European Society of Cardiology ESC guidelines on diabetes, pre-diabetes and cardiovascular disease, which works in collaboration with ESD. He is also served as associate editor in the Diabetes Care from 2003 to 11 and associate editor of Diabetes Medicine from 2005 to 16. He has been editor-in-chief of Diabetic Research and Clinical Practice from July 2016, and in his official IDF journal, he has been published over 450 original papers, and each index is around 88. So with this introductory note, I request Professor Antonio to talk about today's topic, and we'll end up with a discussion after the talk is over. Over to Dr. Antonio.
Thank you very much for the very kind introduction, and it's really a pleasure to be again, let's say in India, even in this way. You know that India is really in my heart because I've been very often in this wonderful country, and I know also that my colleagues in India are used to make a lot of questions when you are presenting something. So this also is very exciting. When you present, it's very good that you have questions because it means that people are following you. So this is something that I learned visiting India quite often. So what I will touch is to have some, let's say, news, if it's possible, on the role of vildagliptin in diabetes management. What I will try to do with you is to put something which was well known only some years ago, but then it begins to be very, very important today when we have learned something more important about the meaning of a glucose control in diabetes, particularly about the value of controlling also glucose variability to avoid the diabetes complications. We start from the evidence, clear evidence that anyhow, controlling glycemia, hyperglycemia is beneficial to control complications. This was clearly emerging from the UK PDS, and not you remember what the problem and the debate when the results of the Avance Accord VADT went out, and particularly the astonishing deleterious effect of a good control hyperglycemia in the Accord, which looked to be a killer of a people more than a benefit for people. But I have to say that what really we learned when several meta-analyses were further published, this is one of the most relevant published in Lancet some years after these trials went out, was to confirm that a good glycemic control is anyhow beneficial in people with diabetes and even with the previous cardiovascular events. You see here that when the UK PDS Proactive, which was a trial with the pioglitazone, and the trials I mentioned before, meaning the advanced VADT and the Accord, all were pooled, anyhow was clear that a good glycemic control was anyhow able to reduce the probability of new events, particularly on non-fatal myocardial infarction, without affecting total mortality. So the message is that a good glycemic control anyhow is beneficial, even in people with a previous cardiovascular event. However, what was really clear from the DCCT edict, which was the first trial which was performed in type 1, but clearly showing that a good glycemic control from the beginning of the disease, or a very early stage of the disease, was able to reduce the complications in type 1 diabetes, in particularly cardiovascular ones. And also this was confirmed in type 2. But what was really clear was that what is important is to start as early as possible a very intensive glycemic control, particularly if you want to avoid the legacy effect of hyperglycemia. The so-called legacy effect, or also defined metabolic memory hyperglycemia, is the phenomenon through which if you control at the beginning in a very good way, in a very intensive way, glycemia, this beneficial effect lasts for many years. We have a follow-up from for example, from the DCCT, that even after 30 years, we have a very good, an advantage in terms of risk reduction for complications in people who were intensively treated from the beginning. And why? Because it's evident that an early increase of glycemia, if lasts enough time, and we have published recent data that the key is 1 year or 2 years, we have several change in the DNA, particularly some epigenetic change, which cannot be reversed. And this impacts on the risk of complication later, even after years. So what is really important is that if you must control as early as possible in the best way the hyperglycemia in people with diabetes. So this is just a scheme showing that it's good, because if you do not control, you see the comparison between people who were receiving or not intensive therapy 1 year within 1 year from the diagnosis, how was the difference in the outcome. But even more recently, a post-hoc analysis of the UKPDS confirmed that if you reduce 1% the A1C in a year, you see what happens in the green picture. If you do this in 2 years, you get the blue one. If you reduce 1% A1C in 3 years, you see what you get in terms of red line. So it's clear that as early as you do a good control, you make a good control of glycemia, better is the prognosis even after 20 years. You see, the follow-up of UKPDS was lasting 20 years. So there is no doubt the good glycemic control is mandatory. A very good intensive early glycemic control is mandatory if you want to have more chance to avoid the appearance of complications in people with diabetes. How vildagliptin can help in improving glycemic control? There are several ways. First of all, let's remind briefly how vildagliptin works. You know that the incretins were discovered by Mike Nauk, a German guy, who was the first showing that if you give glucose orally, or if you give glucose intravenously, the effect on glycemia was completely different. He discovered that this was due to the secretion by the gut of an hormone, with an incretin hormone named GLP-1. Was the glucagon. So this GLP-1, how is acting? GLP-1 is acting in preparing beta cells to secrete insulin. It is not a direct secretagogue. It just prepares beta cells to react when glycemia goes up. And you can explain physiologically what means. You eat, glucose starts to go through the gut in the bloodstream, and the GLP-1 meanwhile is preparing beta cells to react when glycemia goes up during a meal. So physiologically, this is what happens. Of course, you have that also simultaneously, when you have an increase of glycemia, glucagon secretion is reduced or even blocked in order to favor the control of glycemia. How incretin hormones are a body natural way to maintain the glycemic control. You hear here what I already described, but the problem is, what we learn in years is that these incretins not only are preparing beta cell to increase the insulin secretion, but they also favor insulin biosynthesis. They induce beta cell proliferation, and they improve beta cell survival. At the end, the most important effect is this glucose sensing over the beta cells. But at the same time, on the alpha cells, they reduce glucagon secretion. Take in mind this, because the effect on glucagon is very important for what I'm going to describe later. How the GLP-1 is secreted, is very acutely secreted, and the increase lasts only a few minutes in the physiology. And there is these molecules, the DPP4, which acts in cleaving, destroying the GLP-1. So this is the physiological balance. And so molecules which can inhibit the DPP4 clearly can favor an increase and also a longer persistence of the GLP-1 in the circulation. So meaning that you can get a better effect of physiological secreted GLP-1 on beta cells and alpha cells. You know, what is really interesting that the PP4 inhibitors, just because they work in this way, meaning they work in modulating the physiology, and because GLP-1 is just sensitizing the beta cells, the effect of these molecules is to be induce a glucose-dependent insulin secretion. So this is a very physiological action. If glucose goes up, having more GLP-1 in circulation due to DPP4 inhibition, beta cells are more sensitizing and more able to secrete insulin when needed. So this is an adaptation, a pharmacological adaptation of the physiology of hyperglycemia management in men. So this is clearly interesting to see that the vildagliptin improves meal-related beta cell function in people with type 2 patients. And this effect is lasting 1 year. So in this trial, this study, you see, and probably you know very well, because these are studies published several years ago, that the effects on insulin secretion, meaning also insulin adaptation index, which means the possibility, the ability of insulin to be secreted according to the increase of glycemia, is really improved by the vildagliptin. And also, because usually vildagliptin is used in combination with metformin, it's really interesting to see, and not surprising, I have to see, that when vildagliptin is added to metformin, there is a more effect on A1C reduction. So this is a very useful combination. But, and this is really interesting, the effect on vildagliptin in alpha cells can contribute to explain the low risk of hypoglycemia, because how modulated is insulin secretion, at the same time is also modulated the effect on glucagon. So meaning that there is not a complete inhibition of the glucagon, but the glucagon could be available if needed. And this explains why the DPP4 inhibitors and vildagliptin in particular, because this has been described in this study, are really very helpful in avoiding hypoglycemia. But there is another aspect which has been also already introduced by our host. This is the only trial confirming, demonstrating something very, very important, which probably will be more received by the new ongoing guidelines. I know this, so if you want, we can share during the discussion. And meaning the usefulness of starting directly with a combination, more than one drug, and going step by step, as suggested previously for the management of hyperglycemia. This verified trial, which has a 5-year follow-up, was able to show something that conceptually was not new. What I mean was already present, but needed to be demonstrated. And the demonstration was that if you start directly with a combination within using vildagliptin and metformin, and you compare the effect on beta cell durability, meaning how long you can get the good glycemic control, the effect of starting immediately with this combination was better than starting with the vildagliptin alone or metformin alone. So this combination, if you started at the diagnosis, is very helpful in preserving beta cell for a very long time, which is very important if you want to keep the good glycemic control, of course. If you have still good beta cells, there is more chance to keep the glycemic control. I have to say something. You know that in type 1, all the trials are looking at when you want a drug approved for the diabetes management, for hyperglycemia management in diabetes, is mandatory to show and this is a need is required by FDA, European Medical Agency, Japanese Medical Agency, Chinese, all the agencies are requiring an effect on A1C reduction, usually around 0.5% to be considered efficacious. But there is another aspect which also is important to consider. In type 1 diabetes, for example, in DDCCP, it was demonstrated that reduction of A1C was able to reduce the risk for complications very well. Now, in type 1 diabetes, usually you do not have comorbidities. In the DCCT, people were young, without hypertension, without dyslipidemia, they were not obese. So the only risk factor was hyperglycemia. And the studies show that controlling hyperglycemia in terms of A1C, you can reduce the risk for complications. So the question is, if A1C is the best target for overall glycemic control, and you have type 1 diabetes having A1C at a target for all the life, what could be the risk for complications? If A1C is the best and the comprehensive target of glucose control, glucose hyperglycemia is an independent risk factor, the only independent risk factor in type 1 diabetes, the hypothesis is that if you have a good A1C all the time, the risk for complication should be zero. But this is not true. In this study, coming from the Swedish Diabetes Registry, which is the most important registry in the world because it's following all the people living in Sweden. So it's a very comprehensive registry. The authors were able to show that even having type 1 diabetes, showing an A1C target for all the life, the risk of complications, including cardiovascular complications, was not the same of control, but was anyhow higher. This means clearly that A1C is not enough to explain the risk for diabetic complications related to hyperglycemia, including the cardiovascular ones. So it is not surprising that something else must exist in terms of a glycemic control, which can impact on complications. What I'm sharing with you are some data which now are not so surprising, I know. But please put this data at this slide in the context of when we got this evidence. Almost more than 15 years ago, when CGM was just starting. And we were curious. We put a CGM in 9 type 1 diabetes having very good A1C. You see 6.7. No one was higher than 7%. So they must be considered at a good glycemic control. But you see, when we use the CGM, how was the situation in terms of glycemia during the day? There was a huge fluctuation of levels of glycemia during the day in these subjects. One of the problems of glucose variability is how we can measure it. There are a lot of metrics you see here. This is the first list. Then we have a more list, but usually we got an agreement that now we can have usually is the coefficient of variation that could be important. But what is more relevant is that the evidence is so strong that glucose variability is a strong independent risk factor for any kind of a complication in diabetes, including cardiovascular complications. So even if you consider short-term, long-term glucose variability, because the two concepts are, of course, very different. Short-term is how glycemia goes up and down during a day. Long-term is usually how A1C is going up and down, is some variation in years or even in months. But both the situation can impact on the development of complications. How we get some, let's say, useful target to measure glucose variability. These are coming mainly from studies from Louis Monnier. Who, Louis Monnier was he studied a lot the story of glucose variability. And you see here that in this subject of this study, including people not treated with the insulinotropic agents, people treated with DPP-4 inhibitor plus insulin sensitizer, or people treated with the sulfonylurea plus insulin sensitizers. Anyhow, this 36% is also a group of insulin. So you see here that the 36% seems to be the cutoff in order to the 6% as coefficient of variation of glucose variability seems to be the best target in order to identify people at target or not. And this has been adopted by this international consensus published some years ago, in which the stable glucose levels in terms of glucose variability as defined and a CV coefficient of variation less than 36%, and unstable glucose levels are defined as a coefficient of variation higher or equal to 36%. This is very useful when you use a CGM, and you get these measurements directly from the tool, so you do not need to calculate. The story is more complex for A1C variability, where the consensus has been not yet reached. But anyhow, this can help to understand where you are in terms of glucose variability. But why am I introducing this problem of glucose variability? First of all, this is the first study which was able to show in a follow-up of 10 years that fasting glucose variability was strongly and independently related to a high cardiovascular mortality in people with type 2 diabetes, something that was confirmed by several epidemiological studies, but particularly by the post-hoc analysis of all these trials. You see here, the advanced devoted VADT, the famous 3 trials which were aiming to show the effect of glycemic control, the HEMPA-REG all had a accord. So in all these trials, you see that a post-hoc analysis was able to confirm that glucose variability is an independent risk factor for complications. So if you can have a doubt about the value of epidemiological studies, clearly this value of evidence is higher when you consider controlled trials, so placebo-controlled trials. So this means that the evidence is very strong. But what we were able to show just, let's say, last year, in cooperation with the Swedish Diabetes Registry, is something that really is worrying, because we confirm that A1C variability in years is related to higher risk. You see almost all kinds of cardiovascular complications. There is no one which is not linked. But we found out that the risk related to high variability of glycemia is higher in people at target for A1C than in people not at target. Which means that when you have somebody with an A1C less than 7%, having a huge variability of glycemia, this is the condition which exposes the person at highest risk for complications. Probably there is an explanation. Of course, glucose variability by itself could be dangerous, but probably I will touch quite soon, is because people at target usually are also at high risk for hypoglycemia. And we have evidence that when there is a huge variability, you also have higher risk for hypoglycemia. So if people at target are exposed to higher risk of variability, as we demonstrated in the study, a high variability is linked to high risk of hypoglycemia. It's reasonable that this variability, high risk for hypoglycemia expose people at higher risk for complications, particularly for cardiovascular complications. Why I am speaking about glucose variability? Because you know that this concept is relatively new in terms of receiving attention by the clinicians, not only, but because until a few years ago it was just a scientific issue. But now it's because CGM is more and more used, this is emerging as a nearly need to control in the clinical practice. And we have evidence that just reducing average glycemia without reducing variability may be dangerous. Because if you just cut any peak, you increase the risk for hypoglycemia, which is not good. So apparently you have a good control, but you at the same time you increase the risk for hypoglycemia, which of course is not good at all. And you see here that first of all, what is also important that glucose variability correlates with the postprandial cell dysfunction, which is the first event in glucose variability. Of course, eating, introducing more carbohydrates can favor the appearance of glucose variability. And glucose variability is linked to a reduced cell function, particularly in the postprandial state, and particularly in people using oral hypoglycemic agent. Why the vildagliptin fits? How vildagliptin is fitting what I show about the glucose variability? Because this was the first study published many years ago, but I want to stress that what was available did not have enough attention. Because let's be honest, 13 years ago, the story of glucose variability was just, let's say, scientific curiosity, scientific debate. Now we have a strong evidence, we have the possibility to measure, and particularly we have the need to control glucose variability, because in this way we can do something good for our patients. In this study, an Italian group was the first showing that when vildagliptin was compared with the vildagliptin was more efficacious than sitagliptin in reducing glucose variability. And you see here more in details which kind of markers were affected by sitagliptin and vildagliptin, and particularly, you know, MAGE is one of the best index to measure glucose variability. And you see the very significant difference in terms of MAGE reduction between vildagliptin and sitagliptin. Why? Probably vildagliptin compared to sitagliptin had a stronger action on the interprandial level of GLP-1. This is the most accepted, the most accepted explanation for the existing difference between vildagliptin and sitagliptin. But also, there is evidence, and this is really the mirror of what I described in terms of what happens on GLP-1, where vildagliptin is improving, is increasing more GLP-1. On the other side, vildagliptin is reducing more significantly glucagon. So at the end, more GLP-1, less glucagon can explain why vildagliptin is more efficacious in controlling glycemia, but particularly in controlling the variability of glycemia during the day. before going ahead, I have to share with you something which happened at that time, because I know very well the group which published this paper several years ago. There was a huge debate, there was a legal action by the producer of sitagliptin versus these authors, who they had to send all the rough data to the journal to confirm that the evidence that Vilda was superior to Sita in reducing glucose variability, and the data were there. So the evidence is really true and strongly confirmed. The same group demonstrated something even more interesting. They were, of course, evaluating the different aspects of glycemic variation, but also some markers of inflammation and oxidative stress, meaning nitrotyrosine, which is a marker of oxidative stress generation, and interleukin 618 or TNF alpha as a marker of inflammation. And they summarize this into these pro-inflammatory cytokines in an inflammation score. And they found that sitagliptin was very, very good in reducing it was very good in reducing. This is the scheme of the study. These are the people, but you see here what happened in terms of comparison between between sitagliptin and vidagliptin in terms of nitrotyrosine and in terms of sorry, this is in Italian, but you can see the effect on GLP-1 levels and MAGE. So this was really confirmed. And particularly the higher reduction of the MAGE, meaning higher reduction of glucose variability with the vildagliptin, was accompanied by an overall improvement of inflammation. You see that any marker was more decreased when Vilda was compared to sitagliptin, and this was clearly linked to the higher decrease in glucose variability and also a superior effect on oxidative stress generation, which is well documented, is linked to glucose variability. Maybe you remember a very famous paper published by Nonni and Jama or our group in diabetes care showing this. There is another study, because anybody was questioning, or let's say we're very curious about this data. And so this you see here, a Japanese group looking at comparing vildagliptin and sitagliptin on daily glucose control using a CGM. This was a crossover pilot study, J Victoria study. You see here the trial that was designed. And you see here that even this study, the GCM showed that the median 24-hour blood glucose matched highest blood glucose level after supper and hyperglycemia after breakfast were significantly lower in patients with type 2 diabetes mellitus taking vildagliptin than those taking sitagliptin. So clearly, this is evidence which is confirming the previous studies showing not only that vildagliptin decreases glucose variability, but also is more efficacious than sitagliptin. And this is another study looking at the effect of adding vildagliptin on people already using sulfonylurea. You see here, again, consistent is the evidence, is a strong reduction in this. Are we surprised? I think that if you consider the effect on postprandial insulin secretion of vildagliptin and how the secretion of the glucose variability is linked to the postprandial cell dysfunction, we also can understand why the effect of vildagliptin versus sitagliptin on daily 22-hour acute glucose fluctuation was much, much better using vildagliptin than sitagliptin. So in conclusion, hyperglycemia is a key risk factor for diabetic complications, and early achievement of A1C target can help to avoid long-term complications. This is well demonstrated. But beta-gliptin significantly improves glycemic control and helps beta cell preservation. So if you do not believe to glucose variability, at the end of the day, you have enough evidence to consider beta-gliptin as a good tool to control a very early hyperglycemia and to spare beta cells from the damage. So at least these two considerations must be taken in mind. But we have also evidence that glucose variability is a strong independent risk factor for diabetic complications. And vildagliptin not only reduces glucose variability, but is more effective than sitagliptin in reducing glucose variability and its dangerous sequelae. So I mean that glucose variability today should be considered in the management of diabetes as a key target. And we have the evidence that in the class, vildagliptin is more effective in controlling glucose variability. So it's a good tool in our hands to control this new aspect of glycemic control. Thank you very much.
Thank you. Thank you for your nice, elaborate, as well as clear discussion on the why the vildagliptin should be continued and what the advantage over the other gliptins and with the other anti-diabetic agents for the diabetic patients to control the glycemic variability. Sir, you have nicely explained the importance of glycemic variability. It increases the risk of a lot of complications, including cardiovascular complications and many others. So with this, we have nicely understood the situation and learned that vildagliptin is much better than even the other comparator. So it is not a class effect of the gliptins altogether. So even it is better than sitagliptins with a head-to-head comparison. With this, I want to continue with the question answer session. We will first take the questions from the audience. So first start with the one question which is put not maybe directly on the vildagliptin, but we have discussed that CGMS or the glycemic variability measurement, which is nowadays it is available in our country, at least in the major cities. So how, when and which patients are right to put on the CGM device for all the diabetic patients to consider for look for glycemic variability and to find out where to use the right drug and do we need to really do it for clinical practice? To you, sir.
Ideally, any patient, even with the type 2, type 2 not on insulin treatment. Let me explain this position. This is not only my position. Of course, not adapted by the type 1, not adapted by type 2 on insulin. But what about the, this is a consensus coming out on the type 2 not on insulin. It's a consensus endorsed by ADA and ESD that is going out. So you are working on this. This is an important tool for two reasons. One is educational tool, because when you favor the diagnosis of type 2, people are really disoriented. They do not have an idea what to eat, how to, when to eat, and so on. And we have experience that if you put a CGM, just let's say for some weeks, people can learn how they react to different foods. And then they can choose, they can better control. But also, this could be useful to check time to time the situation, because you do not have a clear idea with A1C what is happening during the day. You believe that, for example, with the one drug, let's say, metformin plus sulfonylureas, the person is very well at target, but maybe is too much at target because he's having hypoglycemia. So let's check with the CGM if there is or not hypoglycemia in order to adjust the therapy. So this is not only an important tool in people with diabetes on insulin, both type 1, type 2, but it's an educational tool. And also is very important to help in choosing and adapting the best therapy for each individual. So this is the future, and also the cost will be lower in time. It's like the story of a mobile phone. At the beginning, they were very expensive, but when the use started to be more common, the price was dropping, and this will happen also for the CGM for sure.
Yeah, thank you. So, is there any opinion on the second level, the second best option for SMBG, self-monitoring of blood? Why do you want to put that in a patient care?
But this is not my position. So this is an official position which is coming out, meaning that CGM could be useful in any person with diabetes according to the need. Meaning, again, at the diagnosis is very important because can help people to understand how to manage their disease. After, when you start a therapy and you want to check if something is going, if everything is going well, you can do a CGM to see what happens in real life. But I can share even more. As IDF, we are working on the possibility to use a CGM for the diagnosis of diabetes and prediabetes. Because you think oral glucose tolerance test, which is the best tool for the diagnosis, is WHO, which says telling this, is not Antonio Ceriello who is telling this. WHO says that OGTT is the best tool for diagnosis of diabetes and prediabetes. But 75 grams of glucose is not physiological at all. You never eat so much. Okay, maybe in India, if you take the cakes, you can get so much carbohydrate, high sugar. But why? If you put a CGM, you can see the reality in the normal life of the people, and then you can make a true diagnosis of the situation, diabetes or prediabetes.
Yeah, thank you. So we come to the second question on role of other anti-diabetic agents, be it DPP4 inhibitors or the others like SGLT2 inhibitors, or it can be a combination of fixed dose combination of DPP4 SGLT2, which is currently available in Indian market, or maybe in future, even the European Union is going to approve it, as we have seen in the past. So what is your perspective for this combination in the glycemic variability for the diabetic patients?
No, I agree that this could be a very good combination, particularly if also you have a metformin in the background. But just if you look at the combination of an SGLT2 and the PP4 inhibitor, an SGLT2 gives you cardiorenal protection, also works on glucose variability. They work on glucose variability. So there are two aspects. But if you have on board also a DPP4 inhibitor, you also can better control glucose variability, but you spare beta cells. So you get extra benefit in sparing protecting beta cells. So this is really a very good combination for the management of diabetes, particularly if you use at very early stage. So this is the clue.
That is mostly done in our country as well. So when the patient is diagnosed and patient requires flexible meal times and flexible lifestyle, so that can be a very good option maybe for us in our Indian perspective. Coming to the slightly criticizing question, maybe the vildagliptin does not have a CVOT, which is not marketed in USA, so it did not require CVOT. But it does not have CVOT compared to the sitagliptin and linagliptin, but it has a meta-analysis that shows the CV safety. So from a clinical practice standpoint, as a clinician, how do you take that as an overall safety, and what is your opinion, the CVOT trial versus no CVOT but meta-analysis with CV safety? Which is your take on it?
I think that about the CVOT, clearly this is not so relevant for vildagliptin. I have to be honest. We have all the other trials coming out with the other TPP4 were neutral, because also the story of Saxa and heart failure is honestly questionable. If you want, we go in details, but anyhow, there was, so I think that this story of CVOT in terms of safety is not applicable. So the class is safe. There is no doubt.
And maybe rightly, the CVOT is not mandatory again for the approval at present. So it has withdrawn the necessity of CVOT, which was previously there. So CVOT is not the only thing which is required.
Exactly. Vildagliptin was already approved at that time, and then when they was introduced, and I believe that because the evidence was when the story went out, I agree with the company which decided having data from the other, for the other DPP4 inhibitors showing that they were neutral, why to invest a lot of money to confirm this? So I think that you can understand, no, that because at the end was not expecting a favorable effect, but also no any risk.
So we have a question from Dr. Rishi that can you throw some light on TIR, time in range? So that is an important measure for glycemic control and the glycemic variability. So what is their effect on vildagliptin and other oral antidiabetic agent? Because it is mostly...
No, but yes, we can really. I was not going through much in details because otherwise the presentation would have last hours. We have also data that Vilda is improving the time in range. So us also we have data vildagliptin is improving postprandial hyperglycemia. So meaning that really Vilda is tackling all the aspects of glycemic control, which today are very relevant, meaning postprandial hyperglycemia, glucose variability, and time in range. So the evidence is there. This is more a class effect, meaning all the DPP4 inhibitors are able to do this, but the evidence, at least for glucose variability, is why I decided to stress this, is that we have only for Vilda-Sita head-to-head studies for glucose variability. So let me clarify. Also, Sita in the studies I show was reducing glucose variability, but Vilda was more effective. Why? Probably because it had a different effect on GLP-1, a different effect on glucagon. This is the hypothesis behind. So, in principle, the class is very good for all these aspects. About specifically glucose variability, we have something very strange because we have head-to-head study. You know, never usually we have head-to-head study. Nobody was, for example, comparing DAPA and CETA, DAPA and EMPA. And never we will have this kind of studies. But this independent group in Italy, which was followed then by Japanese and so on, they did this study. I think it was independent study, was not supported by any company. And they found out that, okay, the class is good, but Vilda is more active than Sita. This is the evidence.
Yeah, thank you. So we have another question from Dr. Mishra. Does addition of DP4 inhibitor to SGLT2 inhibitors reduce the genital infection of SGLT2 inhibitor? This is a very common hypothesis and belief. So what is your take on it? If you combine this, does that reduce the infection?
I think that there is no evidence. The evidence is that the problem of SGLT2 is and the infection is a problem of IG. It's not because SGLT2 is producing more infection by itself. The problem is that when you have SGLT2 on board, urine is more rich in glucose, and so can favor infection because we have a problem for microbes that can be very happy. They found a lot of glucose, but it doesn't mean show that if you apply the rules of good hygiene, the risk for infection is not increased. We have data, for example, for our database in Italy. We are following 1.5 million of people with diabetes from years. And we have data about the use of SGLT2 and infection that is not so evident. So what is important is that if you prescribe an SGLT2 inhibitor, you must inform your patients that particularly she has to pay more attention to the hygiene because this is mandatory.
Yeah, thank you. So we have another question from Dr. Shujit that I'm going to reframe the question because we have an option of vildagliptin sustained release once daily 100 milligram is available in our country. So what will be your take? Maybe not many studies are available. Vildagliptin 50 milligram twice daily versus 50 milligram once daily versus vildagliptin sustained release 100 milligram. So which one you feel better for the patient, even for compliance or other issues?
Of course, 100 is better for compliance, but probably I think that unfortunately for many drugs, you see that in some patients, once a day is working, but sometimes you need twice a day because the metabolism is different. It's really very often person specific. I usually, if I have a good compliance, I prefer to split because in this way you are more sure to get constant concentration than just giving once a day. But honestly, it's a decision that you can make according to the person you have in front, according to his or her needs, because it also depends on the kind of job, how is it difficult or not to be compliant with the prescription, which kind of prescription you have, because probably if you have a combination that is be able to adapt to the situation. So personally, I prefer twice a day, but of course we must adapt to the situation.
Yeah, thank you. So we have maybe the last question and maybe the more generalized question. Can the gliptin and the sulfonylureas can be given in the same time or maybe more preferably in the combination as he may be asking? So is that a rational combination?
Is not so rational. You just increase the risk of hypoglycemia. Is the less I do not like. I have to be honest. I do not like this kind of combination.
Sulfonylurea with anything is a risk of hypoglycemia, definitely.
Yeah, so you increase more the risk because you sensitize beta cells and the sulfonylurea are squeezing beta cells. So let's say it's a last option when something you do not, what I mean, you cannot go to insulin, for example. You already have on board everything. Okay, put even a sulfonylureas with all this. Otherwise, it's the kind of why I like the association, let's say even triple association between metformin, SGLT2, and DPP4 inhibitors, because also I would like to have, if needed, a combination between metformin, CETA, and metformin, SGLT2, and sulfonylurea instead of DPP4, because the two actions are almost complementary between let's say Vilda and sulfonylurea. The idea to combine DPP4 inhibitor with the sulfonylurea, even they can be used together. I personally I do not like so much.
Yeah, maybe it can be added on later part if the patient is not a good glycemic control for a reasonable time.
Exactly. If you are unable to get the control, your patient does not like to have insulin because this is the balance. No, because when somebody is not under control, you also should consider the use of insulin. And then there are a lot of barriers, I know, not only in India.
Yeah, unfortunately, people do not like to take their shots. That is a problem, I think, everywhere in the world.
Everywhere in the world, so it's not only in India. Okay, what to do? Okay, you add sulfonylureas because it's okay. You put all everything you have.
So maybe can I ask you a question on this perspective? That what is your use of sulfonylurea in your patients in Italy? Maybe just an idea of how the people are using in Europe.
It's something as I told you. Sulfonylureas now are dropping in use because also the problem is that the problem in Italy, you have a free access to the treatment, so it's not a problem of the cost. Somewhere the problem is the cost, and people prefer sulfonylureas because they're cheap. But I know that, for example, in India, now also these drugs are quite cheap, not compared with the sulfonylureas, but cheap, anyhow cheap. In Italy, everything is free, so you have a more easy access to any kind of a treatment. And sulfonylureas are used as a last because you prefer to be more safe using an SGLT2, using a DPP4 inhibitor, and if needed, because the world is the same, people are the same all around the world, many that don't like insulin. Also, many cannot take a GLP-1 analog, GLP-1 receptor agonist, because the side effects are relevant. Even we speak that it is possible, but no, it's not for everybody. And then what to do? You had sulfonylureas. You said no other chance.
That's true. Because we have seen a lot of serious concern for the GLP-1 analogs in our country as well. Significant nausea and vomiting, and we had to withdraw at least 10-15% of the patients, in my experience.
Exactly.
Yeah. So I think we have finished the questionnaire, and I think thank you again for helping us understand the vildagliptin and its importance in managing diabetes and the fluctuation of glycemia, glycemic variability, and the importance of it, and how vildagliptin is maybe slightly superior to other gliptins. Overall, we had a nice experience with you, and we have learned that how the CGM is to be placed in the patient perspective, and understanding the diabetes control and understanding food response and many things are very important even in our country. So with all, we had learned a lot today with you, and you have also a busy schedule, and thank you again for your time with us. And overall, we had a nice experience, and now I hand over to the session to our organizers, and thank you very much from personally from my side.
It was really a pleasure. Thank you.
Thank you so much, Professor Serlio. Thank you so much, Dr. Siddha. Professor Serlio, the audience we've had today on a weekend towards the night here in India has been actually quite a very engaging one. So people have loved the session, and thank you so much for not just discussing evidence on evidence, but also giving a very clinical takeaway for each of the evidences. So it was something truly like a bench to bedside approach. So well appreciated. Thank you so much, Professor Sergio. Thank you so much, Dr. Sinha, for also enshrining the Indian context and milking out possibly and getting it into the Indian context of what all the clinical pearls of wisdom that Professor Sergio brought to the audience. And dear audience, we thank each and every one of you too for actually taking your time to join on this busy day. And we are very sure that the learnings that you've taken from this educational podium will ultimately empower you to better your patient care and ultimately those outcomes. Last but not the least, we also thank our technology partners who have aided in the very smooth streaming of this webinar. Thank you, one and all. Good day.
Right.